The brain and the nervous system are the most metabolically demanding structures in the human body. They consume a fifth of your total energy supply. They process billions of signals every second. They coordinate every thought, every movement, every sensation, every emotion you have ever experienced. And they are profoundly, specifically, and in ways that most people have never been told about, dependent on a single vitamin to maintain the biological architecture that makes all of that possible. Vitamin B12 is not optional for the brain. It is not a supplementary nutrient that supports general wellness in some vague, non-specific way. It is a structural requirement, an irreplaceable cofactor in the chemical reactions that build myelin, the insulating sheath around every nerve fiber in your body. It is a critical partner in the synthesis of the neurotransmitters that regulate mood, memory, motivation, and the speed at which you think. And it is an essential component of the metabolic process that keeps the neurons themselves, the cells of which your brain and spinal cord are built, biochemically intact and structurally sound. When B12 is insufficient for the brain and nervous system, the consequences are not felt as a vague decline in general health. They are felt in ways that are specific, neurological, and in some cases profoundly alarming when you understand what is actually happening beneath them. Symptoms that seem unrelated to each other, symptoms that seem unrelated to nutrition, symptoms that get attributed to stress, to aging, to anxiety, to poor sleep, to any of a dozen more plausible sounding explanations, while the actual driver continues unchecked and the neurological damage it produces compounds quietly month by month. That is what this video is about. Not the general signs of B12 deficiency, not fatigue, not pale skin, not breathlessness, though those matter. The specific, often shocking signs that the brain and nervous system in particular are not getting enough B12. Signs that most people either do not recognize as neurological or do not connect to a nutritional cause. Signs that, understood correctly, change how urgently you respond. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years in the AA and EE, I have encountered the neurological consequences of B12 deficiency at every stage of their progression, from the earliest sensory changes that pass unnoticed to the spinal cord degeneration that produces paralysis. And what strikes me most consistently across all of those encounters is not the severity of the presentations at their worst. It is the specificity of the neurological signs at their earliest, and how rarely that specificity is recognized for what it is. The nervous system speaks a precise biological language. Every symptom it produces is the output of a specific structural or chemical process. When you learn that language, when you understand why a particular symptom appears, rather than simply that it appears, a symptom that seemed vague becomes a clear signal. A complaint that seemed unworthy of investigation becomes a reason to act. That is what I want to give you in this video. Not a list, a framework. One that makes 8 specific neurological and cognitive signs of B12 insufficiency recognizable, legible, and actionable. Before the signs, I need to give you the biology. Because the biology is what gives each sign its meaning, and in this case, its urgency. I promise to keep creating the most useful and well-grounded videos I can, built on science and clinical experience, to help you live longer and protect the health of the systems that matter most. All I ask is that you give this fairly new channel a chance and hit the subscribe button. If you reached the end of this video and did not find it genuinely valuable, feel free to unsubscribe, no hard feelings at all. But if you give me your time, I will give you everything I've learned for more than a decade in medicine. Please subscribe and let us get into it. To understand what B12 insufficiency does, specifically to the brain and nervous system, as opposed to the broader systemic effects on blood and energy, you need to understand the biology at the level of the neuron and the nerve fiber. Because the neurological consequences of B12 deficiency are not simply the downstream effects of anemia on brain oxygenation, though that is one component. They are the direct structural and chemical consequences of B12's absence from the reactions that build and maintain the nervous system itself. The first and most fundamental role is myelin synthesis and maintenance. Myelin is the fatty, protein-rich sheath that wraps around the axons of nerve cells, the long extensions along which electrical signals travel from the cell body to the next neuron, or from the spinal cord to a distant muscle or sensory receptor. The function of myelin is both structural and electrical. Structurally, it holds the axon in shape. Electrically, it insulates the signal, preventing charge from leaking out of the axon and allowing signals to jump rapidly between gaps in the sheath called nodes of Ranvier, rather than travelling slowly along the entire length. This saltatory conduction is what allows nerve signals to travel at speeds of up to 70 meters per second in a healthy myelinated fiber. Without myelin, that speed drops dramatically. Signals slow, scatter, and in severely demyelinated fibers, fail to arrive at all. Myelin is produced and maintained by specialized cells, Schwann cells in the peripheral nervous system and oligodendrocytes in the central nervous system, and the biochemical reactions they use to synthesize myelin depend on B12 as an irreplaceable cofactor. Specifically, B12 enables the conversion of homocysteine to methionine, and methionine feeds into the production of S-adenosyl methionine, the body's universal methyl donor, which is used to attach methyl groups to the fatty acids and proteins that make up the myelin sheath. When B12 is insufficient, S-adenosyl methionine production falls, myelin synthesis slows, the sheath begins to thin and degrade at a rate that exceeds its renewal, and nerve signals begin to travel less efficiently, a change that produces the specific sensory, motor, cognitive, and autonomic symptoms of B12-related neurological disease. The second mechanism is methylmalonic acid accumulation. When B12 is insufficient at the mitochondrial level, a metabolite called propionyl-CoA cannot be converted to succinyl-CoA through the normal pathway. Instead, it accumulates as methylmalonic acid, a compound that is directly toxic to neurons in ways that are independent of the myelin problem. Methylmalonic acid inhibits mitochondrial energy production inside neurons. It incorporates abnormally into the fatty acid chains of myelin, creating structurally defective sheath material that is more prone to breakdown. And it interferes with the synthesis of odd-chain fatty acids that are essential for neuronal membrane integrity. Research published in the journal Annals of Neurology has documented that methylmalonic acid concentrations correlate directly with the severity of neurological involvement in B12 deficiency. It is not merely a marker of deficiency, but an active driver of the neurological damage. The third mechanism is homocysteine neurotoxicity. Homocysteine accumulates whenever the B12-dependent conversion of homocysteine to methionine stalls. In the brain and nervous system, elevated homocysteine produces several distinct forms of damage. It generates free radicals that cause oxidative stress in neuronal tissue. It activates glutamate receptors in a process called excitotoxicity, overstimulating neurons in a way that damages or destroys them. It damages the endothelium of small cerebral blood vessels, impairing the microvascular supply to brain tissue. And it promotes neuroinflammation through pathways that accelerate the atrophy of specific brain structures, particularly the hippocampus and prefrontal cortex. Research published in the journal Brain has demonstrated that elevated homocysteine is independently associated with accelerated brain atrophy at a rate that is measurable on sequential MRI imaging, meaning the structural damage to the brain is not theoretical, but visible, progressive, and correlated with the duration of elevation. The fourth mechanism, and the one that produces some of the most distinctive and least recognized neurological signs, is neurotransmitter synthesis impairment. Serotonin, dopamine, noradrenaline, and acetylcholine are all synthesized through methylation-dependent reactions that require adequate B12. When the methylation cycle slows because B12 is insufficient, neurotransmitter production falls across multiple pathways simultaneously. The consequences are not uniform. They depend on which pathways are most sensitive to the reduction in methyl supply in a given individual. But they manifest as changes in mood, motivation, emotional regulation, sleep architecture, and the speed and quality of cognitive processing. Changes that are real, neurochemically grounded, and frequently treated as psychiatric disorders without the underlying nutritional driver being investigated. And the anatomical specificity of B12-related neurological damage explains which signs appear and in which order. The peripheral nervous system, the nerves outside the brain and spinal cord, is affected earliest and most commonly because peripheral nerve fibers are the longest myelinated fibers in the body and require the most ongoing myelin maintenance over the greatest physical distance. The posterior and lateral columns of the spinal cord are affected next, producing the balance and motor changes of subacute combined degeneration. The optic nerves and cranial nerves follow, and the brain itself, the cerebral cortex, the hippocampus, the prefrontal regions, shows the cognitive and psychiatric consequences of both the metabolic damage from homocysteine and the white matter changes that accompany extended demyelination. That is the architecture of B12-related neurological disease. Now let us look at the 8 signs it produces, starting with the ones that shock people most, because they did not know B12 deficiency could do that. Just quickly, if this is giving you something genuinely useful, please consider subscribing. It helps this channel reach more people who need this information. What makes these 8 signs shocking for most people is not their severity, it is their specificity. People expect B12 deficiency to produce fatigue and anemia. They do not expect it to produce electric shock sensations down the spine. They do not expect it to produce a loss of the ability to feel where their limbs are in space. They do not expect a paranoid episode in an otherwise mentally well person to be traceable to a vitamin that can be corrected with an injection. These signs are shocking because they reveal how deeply and how specifically the brain and nervous system are wired to B12, and how dramatically things can go wrong when that dependency is not met. The first sign is Lermite's sign, an electric shock or current-like sensation that runs from the neck down the spine into the arms or legs, triggered by bending the neck forward. Most people who experience this have never heard its name. They describe it as a sudden jolt, a wave of electricity, a vibration that runs through their body when they tuck their chin toward their chest. It is startling, alarming, and deeply unfamiliar. The mechanism is direct. Demyelination in the posterior columns of the cervical spinal cord, the uppermost part of the back of the spinal cord, has progressed to a point where bending the neck mechanically stretches and deforms the demyelinated fibers. In a healthy, fully myelinated spinal cord, this stretch produces no sensation. In a demyelinated cord, it generates an ectopic electrical discharge, a spontaneous firing of the damaged fibers that the brain experiences as an electric shock. Lermite's sign is most commonly associated in the clinical literature with multiple sclerosis, where posterior column demyelination is a primary feature. But it is documented in B12 deficiency as well, and in a patient without an MS diagnosis, its appearance should prompt immediate investigation of posterior column integrity, including B12 status. This is not a symptom to monitor, it is a symptom to investigate the same week it is reported. The second sign is a loss of the sense of where the body is in space, what clinicians call proprioceptive loss. This is more than balance difficulty. It is the disappearance of a sense that most people have never consciously registered because it has always been present. The continuous, automatic knowledge of where your limbs are, what position your feet are in, how your body is oriented relative to the ground. Proprioception travels through the same posterior spinal cord columns that carry vibration sense, fibers that run from sensory receptors in the joints and muscles up through the dorsal columns to the brain. When B12-related demyelination damages these fibers, proprioception fails silently and progressively. The person finds they can no longer walk safely in the dark because they cannot feel where their feet are landing. They find themselves looking at their feet when going downstairs because visual information has become necessary for navigation that used to be automatic. They find themselves stumbling on flat ground, unable to explain why. In clinical examination, this produces a characteristic sign. The person sways or falls when asked to stand with feet together and eyes closed. The Romberg test. A positive Romberg, combined with absent vibration sent at the ankle, is a clinical signature of posterior column disease. In a patient with B12 risk factors, it should be treated as urgent. The third sign is a specific and unusual cognitive pattern, not the global memory impairment of dementia, but a selective slowing of processing speed combined with difficulty with executive function, planning, sequencing, switching between tasks, holding multiple items in working memory simultaneously. The person can remember events from years ago with clarity. What they cannot do is think as quickly as they used to, manage complexity as well as they used to, or hold the thread of a task when interrupted. This pattern reflects the white matter changes of B12-related neurological disease, the demyelination of the association fibers that connect different regions of the brain and allow rapid, coordinated information processing. It also reflects the prefrontal cortical thinning driven by homocysteine neurotoxicity, which selectively impairs the higher-order cognitive functions that depend on prefrontal integrity. This is not the hippocampal memory loss of Alzheimer's. It is the processing speed and executive impairment of a white matter disease, and it is reversible in its early stages with B12 correction in a way that primary neurodegenerative disease is not. The fourth sign is visual disturbances that do not resolve with corrective lenses, specifically a blurring of central vision, a central patch of reduced or absent visual acuity called a central scotoma, or a change in color discrimination, particularly an inability to distinguish red from green with the accuracy that was previously possible. BAB12-related optic neuropathy, demyelination of the optic nerve, produces these specific visual changes because the optic nerve fibers carrying the fine detail central vision and color information from the macula are particularly long and particularly myelin dependent. Ophthalmological examination in these patients will often show a temporal pallor of the optic disc, a paleness on the outer side of the optic nerve head that reflects axonal loss. This is a sign that a neuro-ophthalmologist takes seriously. In the context of other B12-related signs, it confirms that demyelination has reached the cranial nerves. Visual symptoms in combination with any other neurological sign in this list should be treated as requiring urgent assessment rather than a routine optometry referral. The fifth sign is an abnormal sensitivity to touch, a phenomenon called allodynia, where sensations that should not be painful are painful, or where the normal stimulus of clothing, sheet, or light pressure on the skin of the hands and feet produces an uncomfortable burning or dysesthetic response. This is neuropathic pain in its specific peripheral nerve form. The sensory nerve fibers that normally carry touch information have been demyelinated to a degree where they are generating aberrant electrical activity. They misfire spontaneously. They respond to normally innocuous stimuli with signals that the brain interprets as pain or intense discomfort. The person may find they cannot tolerate socks, that bed sheets against their feet wake them in the night, that the normal sensation of a handshake has become uncomfortable. This is not a skin problem, it is not a circulation problem, it is a peripheral nervous system problem, specifically small and medium myelinated sensory fiber demyelination producing a pain syndrome whose origin is neurological and whose resolution depends on addressing the deficiency that is causing the nerve damage. The sixth sign is a tremor, specifically a fine tremor of the hands at rest or during precise tasks, or a tremor that appears in a limb that is held outstretched. B12-related tremor is less commonly discussed than the more dramatic neurological signs, but it is documented in the clinical literature and it reflects a combination of mechanisms. Cerebellar involvement from white matter demyelination affecting the pathways between cerebellum and cortex, and the peripheral motor nerve involvement that reduces the precision of fine motor control. The tremor is typically fine rather than coarse, and it may be accompanied by a subtle clumsiness with tasks requiring coordination, handling small objects, writing, using cutlery. In a person with no prior movement disorder, a new tremor, combined with any of the other signs in this list, warrants investigation rather than attribution to anxiety or essential tremor without further assessment. The seventh sign is a disturbance of mood or personality that is neurological in character, specific, a change that the person or those around them recognizes as inconsistent with the person's established character, and that has appeared without a clear psychosocial explanation. Not the flattened mood of early methylation cycle impairment, a more dramatic change, an irritability or agitation that is out of proportion to circumstance, a suspicion or paranoia directed at family members or carers that was not present before, an emotional lability, crying or anger without apparent trigger, an apathy so profound that the person has withdrawn from all activity and engagement. But these changes reflect the neurochemical consequences of sustained methylation failure, neurotransmitter depletion across multiple pathways simultaneously, combined in some cases with the direct behavioral effects of white matter disease in the frontal lobes. The frontal lobes are specifically responsible for impulse regulation, emotional modulation, and the social filtering of behavior. When frontal white matter is involved in demyelination, the behavioral consequences can resemble a personality change that appears suddenly and inexplicably. In a patient with no prior psychiatric history, a change of this character should prompt B12 investigation before a psychiatric diagnosis is assigned. The eighth sign is a change in the autonomic functions, the body's automatic background operations that is unexplained by any other diagnosis, specifically episodes of dizziness or lightheadedness on standing from a seated or lying position, which clinicians call orthostatic hypotension. An unpredictable bowel, alternating constipation and urgency without a structural gastrointestinal explanation. A bladder that has become either overactive and urgent or underactive and slow to empty. A heart rate that seems to vary inappropriately with posture or rest. These are the signs of autonomic neuropathy, damage to the nerves that regulate the automatic functions of the cardiovascular, digestive and urinary systems. The autonomic fibers are among the smallest and most sensitive nerve fibers in the body. In B12 deficiency, they are affected as the peripheral neuropathy extends beyond the large sensory fibers into the small fiber autonomic system. Research published in the Journal of the Neurological Sciences has documented autonomic dysfunction in a subset of patients with significant B12 deficiency. And because these symptoms are diffuse, highly non-specific, and overlap with many functional and systemic conditions, they are among the most consistently misattributed features of B12-related neurological disease. In a patient with other signs on this list, unexplained autonomic symptoms are a meaningful part of the clinical picture. What I want to emphasize before the practical steps is this: the neurological signs I have just described exist on a spectrum of reversibility that is directly tied to time. Hermit's signs, proprioceptive loss, processing speed impairment, visual changes, neuropathic pain, tremor, personality change, autonomic dysfunction at the early to moderate stage, all of these are potentially fully reversible with adequate B12 correction. At the advanced stage, recovery is partial, slow, and in some features, permanent. The single most powerful intervention available to anyone experiencing these signs is not a specific medication or a complex clinical protocol. It is the decision to investigate now rather than later. The first step is getting the neurologically appropriate investigation. Beyond the serum B12, methylmalonic acid, and homocysteine panel that I have recommended throughout this series, neurological B12 deficiency specifically warrants a clinical neurological examination, assessment of reflexes, vibration sense, proprioception, coordination, and gait to document the presence and extent of nervous system involvement. In the presence of spinal cord signs, Hermit's proprioceptive loss, leg weakness with brisk reflexes, spinal MRI should be arranged. The characteristic finding on MRI in subacute combined degeneration is T2 signal change in the posterior and lateral columns of the spinal cord, typically most prominent in the mid-cervical and mid-thoracic regions. This imaging finding confirms the diagnosis, defines the extent of structural damage, and provides a baseline against which recovery can be measured. In the presence of cognitive or personality change, neuropsychological assessment and brain MRI should be considered alongside the metabolic investigation. Elevated homocysteine with white matter changes on brain MRI is a specific combination that points directly to B12-related neurological disease rather than primary neurodegenerative pathology. The second step is urgency calibration, matching the pace of the response to the pace of the damage. For the neurological signs in this video, particularly Hermit's sign, significant proprioceptive loss, visual disturbance, and motor involvement, the appropriate pace of investigation is not the standard GP appointment scheduled for the following fortnight. Research published in Practical Neurology has confirmed that the duration between neurological symptom onset and B12 correction is the primary determinant of neurological recovery, and at the level of spinal cord involvement, every additional month of untreated deficiency represents structural damage that may not be reversible. These symptoms warrant urgent investigation, which in practice means requesting an urgent or same-week blood panel and a prompt neurology or internal medicine referral if the signs are present. I am not suggesting alarm for its own sake. I am suggesting that the urgency of the investigation should be proportionate to the biology. The third step is treatment route and intensity. For neurological B12 deficiency, as opposed to mild systemic deficiency without nervous system involvement, Intramuscular B12 injections are the preferred initial treatment in most clinical settings, regardless of whether the underlying cause is pernicious anemia, dietary deficiency, or medication-related depletion. The reason is delivery speed and reliability. Intramuscular injections achieve high serum B12 concentrations rapidly, bypass any absorption impairment, and deliver therapeutic levels to the nervous system faster than oral supplementation at any dose. The initial injection schedule, the neurological involvement, is typically intensive, alternate day or daily injections for the first 2 weeks before transitioning to a maintenance frequency determined by the underlying cause. If pernicious anemia is confirmed, maintenance injections are lifelong. If the cause is reversible, dietary, medication-related, the maintenance strategy can be adapted. But in the acute phase of neurological involvement, the intensity of initial treatment should not be compromised by uncertainty about the long-term management plan. Treat the neurology first. Investigate the cause in parallel. The fourth step is what I call neurological rehabilitation context, and this is a component of B12 deficiency management that is rarely discussed but genuinely matters for recovery. The nervous system's capacity to recover from demyelination depends not just on the availability of B12 for myelin reconstruction, but on the functional use of the affected pathways during recovery. Balance and proprioceptive recovery, in particular, benefits from specific physiotherapy input, exercises that challenge the proprioceptive system in a structured, progressive way, stimulating the remaining functional fibers and encouraging compensatory neuroplasticity. For patients with significant gait and balance involvement, physiotherapy referral should be arranged alongside the medical treatment. For those with cognitive involvement, cognitive engagement, reading, problem-solving, social interaction supports the brain's adaptive capacity during the recovery period. Recovery from neurological B12 deficiency is not a passive process. It is one that responds to active, structured rehabilitation in ways that the prescription alone cannot achieve. The fifth step is monitoring with neurological specific follow-up. At 6 weeks, 3 months, and 6 months after beginning treatment, neurological examination should be repeated and documented. Vibration sense at the ankle is one of the most sensitive clinical markers of posterior column recovery. It tends to improve measurably within 3 to 6 months of adequate treatment in patients with early to moderate involvement. Cognitive reassessment using standardized tools where available should be performed at 3 and 6 months. Brain and spinal MRI findings, where obtained at baseline, should be repeated at 6 months in patients with significant structural involvement to document whether the imaging abnormalities are resolving. The combination of clinical examination, metabolic markers, and imaging follow-up provides the most complete picture of the recovery trajectory and identifies early those patients in whom the response to treatment is insufficient, in whom the clinical approach needs to be reviewed. I want to share something with you about the nature of neurological B12 deficiency that I think matters beyond the clinical details. Something about why the nervous system is the organ system where this deficiency does its most quietly devastating work. The brain and nervous system are the only organ systems in the body whose function is simultaneously biological and experiential. The heart pumps blood, the kidneys filter waste. These are functions whose impairment is measurable, whose consequences are physiological. But the nervous system's function is thinking, feeling, remembering, moving, perceiving, being present in the world. When the nervous system is damaged, what is lost is not just a biological capacity, it is part of the person's experience of being themselves.